Hello everyone and welcome to today's Connect and Learn webinar on social connection, pain and opioid use, the ALMA project here at Turning Point. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. My name is Rebecca and I'll be facilitating today's webinar. This webinar is a part of a series of Connect and Learn webinars designed to support AOD clinicians throughout Victoria. The webinar series is funded by the Victorian Department of Health and hosted by Turning Point. We like our webinars to be interactive, so please ask questions via the Q&A function. The questions will be collated by me and answered by the presenters at the end. Please start, whenever you think of a question, please start typing them rather than at the end when it gets a little bit busy. We like to answer as many of those as we can. We encourage you to stay to the end of the webinar, complete the exit survey. There will be a QR code that will appear on the last slide. If that gets missed, we'll email it to you later. I'd like to welcome back Dr. Shalini Araganiri. Thank you so much, Shalini, for joining us again. And I'd like to introduce to you for the first time for Connect and Learn, Dr. Angela Simpson. Shalini is a consultant addiction psychiatrist and clinician researcher. She's Deputy Clinical Director at Turning Point and Deputy Head of the Department of Psychiatry at Central Clinical School, Monash University. Shalini's clinical and research interests include methamphetamine use and mental health problems and women's health and addictive disorders. Angela is a health psychologist and research fellow. She is the project manager of this project. Angela has experience in the AOD sector as a clinician, researcher and evaluator. Thank you both so much. I'll hand over to you, Shalini.
Thanks very much, Rebecca. It's a pleasure to be able to join everyone today to talk to you about this project, and really lovely to be able to share our learnings with you. Today, we're going to talk to you about a project that first focuses on an approach called social prescribing. Our project's called OP-ALMA, and it specifically focuses on opioid use and pain and loneliness in older adults. We were really lucky to get some funding for this project and supported by Gandel Philanthropy and the Eastern Health Foundation. And we delivered this project over the last 18 months in partnership with Coda Victoria. So just taking you through some of the project team and a big thank you to everyone involved in delivering this project. We delivered it at Turning Point here in Melbourne, with myself leading it and project lead and research fellow Angela, who's going to talk to you a bit more about the project today. And also Sally Brown, who's a psychologist in our team, and Celeste Penny, who did a lot of the link worker function in this project. So taking you through some of the background of this project, the project's a little bit left field for us here at Turning Point. As you all know, we're a drug and alcohol treatment service, and most of our core business, our core work focuses on the treatment of substance use disorders. But increasingly, as many people who work in AOD are aware, there's quite a big overlap between opioid medication use and chronic pain. And so increasingly in some of our specialist clinics, we see a lot of people presenting with a history of chronic pain. And in Australia, as you can see, this is a significant problem. 1 in 5 Australians aged over the age of 45 has identified as having chronic pain. And people with chronic pain are 5 times as likely to actually have limitations in their daily activities as a result of that. In services like ours, in specialist addiction services, for instance, we're often seeing one end of the spectrum where people may have been started on opioid-specific medication many, many years ago and may have become dependent on that medication over a course of time. A lot of investment has gone into educating prescribers around opioid use and the risks of opioid analgesics. But on the other side of that is also resourcing the support for people living with chronic pain. So for instance, telling people that the medication might be harmful is only one part of that story. The other part of that story is actually being able to invest in psychological supports, non-medication specific supports, and supporting those constructs that actually underpin both the opioid use as well as the pain disorder. So for us, we really became interested in this because there was an underlying sort of construct that underpins pain and addiction for many people. We know that for older adults, 1 in 3 older Australians report feeling lonely. And over the course of COVID, we've certainly heard a lot about the impact of isolation and loneliness. A report released by Curtin University just last week highlighted that loneliness is estimated to cost Australia $2.7 billion each year. So a really massive kind of burden and public health burden, essentially. And loneliness is also one of the underlying ailments that's come up during the pandemic. So even prior to the pandemic, it was estimated that there was about a 10% increase in people reporting loneliness and a lack of social connection. And during the pandemic, that's only worsened for many people. Now, it's a little bit of a sidestep, a shift in the paradigm of healthcare to think about loneliness as being part of our core business. But if you think about the end effects of that, the end effects of isolation and lack of connectedness, we know that loneliness increases the risk of early death from any cause, so that's physical and mental health causes, by up to 26%. So this is in the same order of risk as obesity, for instance, a really clear sort of risk factor that we invest a lot in trying to change. So kind of putting that out there in terms of thinking about isolation and loneliness being one of those modifiable risk factors that we might be able to change. In terms of thinking about how this is relevant, particularly for older adults, the impact of social connection in older adults, or the lack of it, has been found to be comparable to that of physical exercise. And meaningful connection has been demonstrated to be a key ingredient in improving quality of life, a reduction in sort of perceived pain and pain tolerance, improving mood and reducing anxiety, and most importantly, improving function. So increasing the capacity for people to engage in their daily activities. But despite all this evidence, I think it still becomes quite challenging to treat in traditional healthcare settings, partly because for the individual, raising this as something that they want to work on with their health provider can be really difficult because of anxiety, because of depression, because of their pain in itself, limiting their capacity to be able to engage in activities. Fear, cost, for instance, is also one of the major problems. And just having the confidence, the capacity to engage in activities. For clinicians, I mentioned that this is a bit of a change of people thinking that this is part of their core business, but also for many clinicians in many settings, time constraints, knowledge constraints as well, and their capacity and confidence can actually impact on their ability to deliver this. So this brings us to an approach that has been growing over the last decade or so here in Australia, and is really drawing on evidence that has been around for probably the last 2 decades in the UK and internationally. Social prescribing essentially refers to the sort of approach where healthcare providers refer patients onto an individual who might be called a link worker or a community connector, and that individual is responsible to help the individual collaboratively to design a non-clinical prescription, essentially, to help that person actually engage in social connections for their health and well-being. So it takes this step that connects people to what we call the third sector, and that might be community resources, community capital, also looking at broader holistic health needs and well-being needs. Now, in terms of the types of activities people might be referred into, that can include a whole range of different things. This is an example from a pilot program in the UK, and includes in the top most common things includes things like physical activity groups, for instance, or mental health groups, support groups for long-term chronic health conditions. Also might include a whole range of other activities, for instance, things related to other health needs or care needs, welfare needs, and other community-based activities and volunteer work. In terms of older adults specifically, it's probably quite intuitive to understand that this is an approach that could be really relevant for older people, particularly because we know of that impact of isolation and disconnection for older adults. It can be really challenging to sort of navigate a lot of the resources out there as well at this stage in life. The impact of potential benefits, though, of having social connection is really clear. This includes clear changes in sort of resilience, that's mental health, psychological quality of life, capacity to function as well in terms of mobility or impact on pain, and delaying admission or preventing admission to hospital or nursing home systems as well. So this, as I was saying, has been growing in Australia over the last decade or so. And in pilot programs, I think what's been explored in terms of what is going to be a barrier to implementing this more broadly has been raised as one of those issues with the way we currently deliver healthcare. For instance, in a College of General Practitioners Prescribing Roundtable in 2019, 67% of people surveyed said that they'd be likely to attend a community program if their health provider specifically referred them. And 75% said they were likely to attend an appointment with a community support worker if they were referred by their GP or their primary care provider. But 58% said they were likely to attend activities but wouldn't attend because of the following reasons. And so these are the reasons where, for instance, many GPs currently work in this area and would routinely be actually sending their patients along to different things. But the actual efficacy of that linkage, the capacity for the person to kind of hear that in the room and then go out and do it themselves, can actually be challenged by a whole range of real life factors, really. And so this is where an approach like social prescribing can be so important. It's about addressing these barriers and about being able to find a good fit for the individual and an individualized reason for that person to be able to connect. I've mentioned a couple of times this role of that link worker individual. And this was a really important thing that we brought to this project in thinking through what that function would look like. What's really important for link workers is that they have to have a really comprehensive and in-depth knowledge of what exists in that community. And also that they need to have or be able to kind of develop relationships with the services and community supports for that area. It comes down to that relationship that person has with those supports and those providers that actually leads to the success of that linkage. So it's important that that link worker was a good communicator or had good interpersonal skills, that they had that local knowledge. And then also previous studies have suggested that need for training and supervision and ongoing support as well, because it can be a pretty challenging role. You're engaging in kind of ongoing discussions with individuals who might come from a whole range of different backgrounds and different health challenges. So it is a role that requires a little bit of investment in time and support. And that individual needs to also be able to manage those sort of boundaries of the individual working with them over the long term, so that there isn't this dependent relationship that at some point may need to end. So these roles, these kind of factors are what we thought about when we were developing this project. I'm just coming on to the sort of evidence base that exists in Australia. So this, as I was mentioning, has been growing internationally, and over the last 3 or 4 years has really kind of increased across Australia. I've listed a few pilot programs that have been running here in Melbourne, including a pilot that's been running out of the Bayside neighbourhood house programs. The first pilot here in Melbourne was at IPC Health, which is Community Health Service in Deer Park. There's also been a pilot in the Macedon Ranges, and a much larger kind of connected program running through primary health and wellways in Queensland. So many of these projects have started up at around the same time, and most of them are collecting sort of evaluation information. So it's a really exciting time to be working in this space. Our project today that we're talking to you about will have some findings, and these findings kind of occur in the context of a whole range of different things coming through. I think in this context as well, we've been really excited to be able to work as well with the Royal Commission into the Victorian mental health system, and kind of they're thinking through as well about how this could be translated into the local adult mental health wellbeing hubs. So a lot of potential for being able to help people across a whole range of different health problems, so not just mental health problems or addiction problems or pain problems, but actually this transdiagnostic underpinning across a whole range of different factors. So at this point, I might hand over to Angela to talk to you a little bit more about our specific project.
Thanks, Shalini. So what we're looking at here is an overview of the OP-ALMA project. And just to, I guess, describe who we were hoping to engage with in this program, our focus was specifically on older adults, so aged over the age of 65, who were living in the Yarra Ranges Shire. We were also hoping to support older adults who were living with chronic pain and were currently prescribed opioid-based medication to manage their pain. So this was our target group who we were hoping to support to increase their social connections during our program. As our flowchart or our diagram here shows, there were quite a number of steps involved in this program, starting at the beginning with a very comprehensive assessment of the older adults' current social engagement. which then led through a process of collaborating with the older adult to come up with a formulation and identify targets for increasing social connection. At that point in time, the evaluation team handed over the older adult to our link worker. As Shalini mentioned, our link worker played a vital role in supporting and helping the older person to engage in activities that they had identified an interest in. And certainly tracking each person's progress in terms of were they connecting with the target group, were they engaging, following through. This was a big part of the team's role. As the diagram also shows, we were focusing very much in the online space in terms of online groups, supports that would be available to older adults, particularly given that COVID restrictions were in place pretty much the entirety of the program. So while initially we had anticipated and hoped that we would support older adults to engage with face-to-face activities within their local community, we certainly had to change our direction very quickly, so that we were now focusing on how could we support older adults to connect with meaningful activities in an online space. So I'll speak a bit more to that in a moment in terms of the challenges that were faced, that we faced with navigating an online space. So next slide, please, Shalini. So in terms of our plan for supporting our participants, a big part of our initial assessment was engaging in a social network and asset mapping task. I see that someone has made a comment referring to David Best's social capital work, and certainly we acknowledge that the assessment we developed was based on some of David Best and colleagues' work. So certainly we were very interested in getting an understanding and appreciation of, I suppose, what a person's world looked like initially. And as part of that asset mapping process, we were interested in 5 different domains or categories in an older adult's life in terms of what they were already engaged with in the areas of sports and recreation, arts, culture and faith, employment, volunteering, education and training, pain, peer and community supports, and professional services. So a big part of the role of the evaluation team, which was Sally and myself, was to get a clear understanding of what level of engagement the older adult already had, what were the barriers that were preventing this person from engaging in additional things. And a big part of our collaborative discussions with each participant was to identify how we could overcome any barriers to assist the person to engage with some new social connections. So certainly part of the criteria for taking part in the program was for participants to have a desire to increase social connections. So this was something that they had already identified they would like to work on and become more connected with. So following this consultation with our participant, we developed individual social connection plans. And these were something that were highly valued by each participant, as it wasn't about providing sort of a blanket approach, assuming that we know what's best for someone to engage with. Rather, it was about, providing that each participant with the opportunity to identify what would be meaningful for them. And that was feedback we received from participants that was particularly welcome. One thing to note at this point is that all of the contact with the evaluation team and subsequently our link worker was conducted over the phone or via Zoom once we reached the point where our participants had the technology and were confident or willing to try Zoom. I won't say confident because we certainly worked to support participants to increase their confidence to use technology. In order to allow online connections, part of our change in our project design was that we provided our participants with the use of a tablet device for the duration of the program. So some older adults that were involved in our program had some previous experience using perhaps a smartphone, may not have used a tablet before. So certainly a role of our team was to provide some technology support and empower our participants to pick up the tablet and give it a go. And another big piece of the initial planning of the project was developing our online connection resource directory. As Shalini mentioned, a vital part of the link worker's role is to know the groups, have relationships with community supports that we could link people in with. Given we were moving into an online space, which opens up more possibilities outside the community, this meant we needed to develop a comprehensive list of options of what would be available for older adults to engage with. So one of the challenges that quickly became apparent for us was how we could overcome this digital divide, which is spoken about quite a lot with older adults, and can be a real factor which excludes older adults from participation in a number of areas. We spent a lot of time consulting our steering committee and Code of Victoria to get some advice on how to support older adults. And nevertheless, we had to overcome some issues in terms of providing the device, providing internet connectivity for our participants, and then finding appropriate targets for online connection. So we certainly felt like we were flying a bit blind at times, particularly because we were doing a social prescribing project, which is traditionally aimed at getting people out of the house. However, we were now working with people being in the house, and how could we connect them to external supports while still at home. So we had to make many changes given COVID, as I've said. The other point to make was that all our contact was now not face-to-face. We didn't actually meet our participants face-to-face at any stage. This was all done remotely. Thanks, Shalini.
So, I think moving to some of the results, which we're really excited to share with you, just keeping that in mind, that this project was very much developed prior to COVID, and then actually running it through the pandemic. We really had lots of changes that we made, but we're really excited to be supported both by our partners and our funders to be able to make those changes. Because what we ended up delivering was, the small pilot program that actually was able to, I think, scope a new space for social prescribing, in the sense that this looked at online connections, and it looked at online connections in older adults. Both of those were sort of novel and really interesting, I think, and hopefully will help us kind of think about the space in a bit more detail. So in terms of our results, we aimed to get 15 people in, and we got 14 by the end of the project, of whom 50% were women, and 9 participants were able to complete both the baseline and the post-program measures at the end of the program. And so that was a group that we are basing the rest of this data on. The whole group, the average age was 73, and 78%, interestingly, actually reported living with someone else, a spouse or a partner, and only 22% lived alone. We were somewhat surprised by that, given that the project specifically was aiming to recruit people who reported a sense of loneliness. And people were, during the pandemic, largely at home during lockdown with their spouse or their partner. 92% or 93% were retired, and on average, people had been living with pain for a really long time, for over 26 years. And so that's a really, testament to the fact that people were wanting to kind of engage in an intervention like this, despite that huge burden of chronic pain. And on average, people are reported taking pain medication for about 16 years. In terms of loneliness, 7 out of 9, so the majority of participants got in that range of being at risk for social isolation. We had a range of different measures. If people are interested in the measures, perhaps pop that in the chat, and we can take you through some of the more explicit detail around what we used and how we used to map these. But on average, there was no difference between the overall loneliness score at the baseline to the end. But what we did see was that a third of the participants actually were moving in terms of their significance and severity of the loneliness. So people were scoring in the moderate and very severe range at the start, and post-program, only 11% were in that very severe range. In terms of pain, being one of the core things that we were aiming to change by this intervention, people were asked to rate their pain from 0 to no pain to 10. And on average, this was both their average pain and their current pain at the time that they were asked at the interview. And so you can see there that pre and post intervention, that both of those scores went down to the reporting of average pain and current pain, with a 78% decrease, 78% of participants reporting that decrease in the average pain and 56% reporting a decrease in current pain. And then if we look at a whole range of things that weren't necessarily the core aim of the intervention, but we were looking to see whether people's mental health generally improved. And on average, people actually reported significant changes in that over the course of the intervention, keeping in mind too that this was continuing to be delivered during the course of the pandemic. All of these participants were in lockdown during the course of this as well. So also they had very limited social connections because, as you can tell, that they were in the older age group, and so had a lot of risks with being able to kind of leave home and in the context of the pandemic. And so we were really surprised and encouraged by seeing these results, seeing that 44% reported a reduced depression symptom profile post-program, and 67% reported reduced anxiety symptom severity post-program. So in summary, we saw kind of positive changes across those categories. One of the aims that we were hoping to develop through this intervention was really looking at sort of also medication use and opioid use specifically. We'll talk a little bit more about some of the key learnings later, but I think for us, it was a shame that we weren't able to get more robust data around medication use. We asked people about their self-reported medication use, but for the majority of participants, we weren't able to get that detailed sort of medication summaries from their general practitioners during COVID. It's going to appreciate, I think many primary care providers were under the pump during the pandemic, and we had a lot of challenges sort of engaging across the board primary care in delivering an intervention like this. So fortunately, we weren't able to look at across the board medication use, but I think that change in sort of pain tolerance was great. I might hand over to Angela to talk a little bit about some of the qualitative data that we're also getting through this project.
Thanks, Shalini. So at the end of our program, which was the duration of the program varied with participants being involved anywhere from between 6 weeks to up to 3 months, I think was the longest involvement in the program, again, which depended on a variety number of factors. But we made efforts to conduct one-on-one interviews with each of our participants at the end of the program in order to get some of that rich qualitative feedback about their experience of doing something which was quite novel to them. And a lot of people had reported feeling quite concerned about the technology side of things at the beginning of the program. But really pleasingly, we had a lot of positive feedback at the end of the program about how confident they were now feeling to access a Zoom meeting or to use the tablet. A number of participants were very excited to buy their own tablet, identifying that there were so many uses for it. And so that was very encouraging to see. One thing they did appreciate was the individual technology support, which we provided to them. And also some of our connection options were contacting local sort of neighbourhood houses or community houses to get ongoing technology support to increase confidence. So that was, I think, one thing that is worth highlighting, that although we had our concerns about how older people would adapt to technology, they were very, very eager to embrace it and continue beyond the life of the program. So in terms of the other sorts of feedback we received, participants highly valued their participation and also appreciated, as I mentioned before, the individualised nature of the social connection plan. It was, they appreciated the time spent in identifying meaningful activities for them. As these comments are sort of reflecting on the screen, there was a lot of sort of broadening of opportunities and feeling that while previously they had no idea of what was available, particularly in the online space, they were now aware that should they want to increase connections, there were many opportunities for them to do that. So there was a real theme that emerged from our interviews with participants. Some participants did endorse that they did notice that their pain had decreased, acknowledging that perhaps that was a result of now being having their mind occupied with other things, feeling engaged and part of something other than themselves. So certainly feeling like there was that increased connection, that their opinions did matter, and that they still had ways to engage with others and be seen and heard. So overall, we received lots of positive feedback from our participants. A big part of the program, as Shalini mentioned, we spent quite a bit of time trying to engage healthcare providers, and we stayed in contact with all GPs of the participants who took part in our program by sending them copies of the social connection plan, giving them an update at the end of the program with a summary of the activities that their patient had identified as being a target for them, in the hope that GPs or other health providers would be able to continue to support each older adult to engage with activities beyond the life of the program. So one of the things that we also developed, as I mentioned before, was the Social Connection Directory, which was a big undertaking, which we received lots of support from social work students who were doing placement at Turning Point, and the team all contributed to pooling together a range of online connection options for older adults. One thing that became apparent once we had this directory compiled was that we were thinking about how best to share the findings of these different connection options, because certainly we were hearing that older adults were not aware of what was available and would really appreciate being informed of what was out there. So part of our process of developing resources beyond the project was to transform our database into a series of 4 postcards, I was going to say 5, a series of 4 postcards which captured 4 different categories of connection options for older adults. So the example on the screen is our postcard we devised for online activities for older adults. So thanks, Shalini. So we also had a postcard which had technology support, so options for older adults to access help with a tablet or advice that you could access computers at the library. We also had community groups card, which involved things such as walking groups, photography groups, and social groups, some of whom were delivering their sessions online during the pandemic. And certainly Facebook groups was another thing that we had compiled for the older adults in our group, which included things like wellbeing groups, gardening, pain management, and library groups. The idea of the postcards was that they were then disseminated to GP clinics throughout the Yarra Ranges Shire and throughout our networks, in the hope that if these were placed in waiting rooms, an older adult might pick it up and be interested to find out more in terms of each of these categories. We did incorporate the use of QR codes so that they could be easily scanned by a smartphone if an older adult wanted to find out some more information about how to increase their connections. Just to speak to the social connection, the database that we developed, that has been shared with that has been disseminated and shared with the Yarra Ranges Council and the Knox City Council to be incorporated in their websites. And additionally, we learnt about another social prescribing project being conducted called Living Our Best Life Project, who have also been working on developing a resource directory in terms of face-to-face contacts. So they certainly appreciated being able to incorporate our online options within their databases. Another thing that we created was what we called a complementary resource workbook. And this was one way of providing more information to the healthcare providers in the Yarra Ranges Shire, and specifically the GPs of the clients who were involved in our program. The booklet that we put together provided an A4 version of the postcards, the social connection postcards we just showed on the screen, and also a series of pain management resources which we developed during the life of the project. And so this was what we hoped would be a resource that could be of use to GPs and encourage conversations around social connections. The pain management resources that we developed were specifically targeted for older adults living with chronic pain and taking opioid-based medication. So the series of postcards included one that involved some practical strategies and a little bit of psychoeducation about how to manage pain flare-ups. Another one looked at addressing loneliness and ways to start increasing your connections. We also included some resources around relaxation and sleep, knowing that these are some areas that certainly are impacted with the experience of chronic pain. So these resources were circulated, as I said, to GP clinics in the hope that this could be of use to more clients who we weren't able to reach with our program. So that was a big part of our the project work as a way of ensuring some type of footprint beyond the life of the program in terms of building capacity and perhaps confidence of providers to address pain management with an older adult. And there's an example of our sleep hygiene, which, as I said, is providing information specific to this age group in terms of how sleep is impacted as we age and some appropriate strategies for improving sleep. Thanks, Shirley.
And I think a couple of questions might be coming through at the moment, just asking if we are able to share the slides and the resources. And yes, absolutely, we're happy to share the PowerPoints and also these resources. We have got the postcards as PDFs that are available for download, and we also have the actual individual complementary resources that we're happy to share. What we'll probably do is when the video recording of this goes up, we can link to those resources, and we can also direct people back to the Turning Point website where those resources will be available very soon. Just moving through to, I guess, some of the key learnings we kind of had at the end of this project, and to give you a sense of where this project has taken us. As I mentioned, we developed it prior to COVID, and we've had about 18 months working on it, and we've completed it about 3 or 4 months ago. And over the course of the project, I suppose the aim of the project through the whole thing has been very much to kind of think about helping people develop confidence, capacity, and level of function underpinning these key problems that they were facing. So opioid use, chronic pain, and mental health challenges such as depression and anxiety symptoms. I think despite the limitations of sort of COVID pandemic and also I think being a health service during this whole intervention, I think the capacity of us as a health service delivering an intervention like this was limited at times as a result of the pandemic. But I think we were really happy to kind of come out the other side and be able to see some individuals finish the program and have such great results. I think for us, one of the new spaces this project kind of took us in was really kind of looking at that online connection space. And as Angela mentioned, this was really a pivot because we had to as a result of COVID. But I think what we learned from it was really that for many older adults, that digital divide was something that we could support people to navigate through and be able to, give them confidence in a space that would open up lots of different options, not just the social connections we've suggested. We had lots of stories where for some people that actually during the pandemic allowed individuals to be able to see their family members or engage with their family much more in a way that they might not have been able to had they not had that capacity to engage with technology. It kind of raised for us, I suppose, that capacity to kind of take this into other spaces, including sort of the evidence base for treatment in substance use disorder, in a whole range of other mental health conditions as well. I think the challenges for us in delivering this project were around kind of, first of all, engagement with primary care. As I mentioned before, a lot of the social prescribing model drawn from the UK is largely based in a general practice environment, and that general practice environment being key to initiating that social prescription, initiating that link to link workers. And through a process of evolution in other countries, that role of that general practitioner has become useful but not critical to the whole model. And I suppose what we've seen here in Australia is probably something similar in the sense that with the healthcare system being kind of vulnerable as well to other changes in the course of COVID, a lot of general practice is moving to telehealth or telephone only models, that primary care providers in this project weren't able to kind of be as engaged as fully as we would have liked. And I think for many GPs, we had a number of GPs in our steering committee, for instance. I think also that feedback about the time that something like this would take to incorporate into sort of a standard mainstream primary care workflow can be a real challenge as well. So I think for us, I think if we were to deliver a project like this again, thinking through how we would involve primary care in that intervention in a more fulsome fashion was really important. Thinking through, for instance, at the end of the intervention, as Angela mentioned, for all our participants, we were able to kind of generate a summary that included the linkages that we were able to help the participant achieve, and also those kind of key areas that they were interested in working on, and send that summary back to the primary care provider, even if the primary care provider wasn't able to be part of that intervention. I think we've talked a bit about the link worker role and how central it is. I think there have been different models kind of utilized to look at link workers across social prescribing interventions. For us, I think the key learning there was that we could deliver a link worker role that wasn't based in the community itself, that was based remotely. And that was a really interesting sort of space. We've not seen that delivered before. I think what was really important though was for that link worker to still be able to kind of develop connections with some of the local community supports, even though some of the connections were online, to be able to have really good relationship with some of those connections, be that through the telephone or online space. So for instance, with some of the Facebook groups, developing relationships with the facilitators or the administrators of some of those groups, so that we could still have that sort of warm referral for that individual. We could still have an understanding of what that group or that connection was going to be like before we referred someone in. I think I've spoken a little bit about us moving to the space from left field, from working in an addiction treatment environment. And I think we were really happy to be able to deliver something like this that could help an individual across a whole range of problems. But alongside this, there's been a growing evidence for the use of this approach in substance use disorder, as someone mentioned before, starting from work led by David Best, but also a whole range of colleagues in the UK and in Queensland, where Genevieve Dingle and a whole range of people working at Wellways in Queensland have really kind of been leading the charge on the Australian treatment space in terms of substance use disorder. So we're hoping that some of these key learnings might be things that we can kind of take forward into other projects as well in the future. So I might just get Angela to rejoin me as we wrap up, and happy to take some questions from everyone. Again, if you're interested in kind of the resources in the slides, we're more than happy to kind of share that with everyone as well.
Thank you both so much. And I'm sure everyone would love to receive the slides. So thank you so much. We'll have them emailed out to people in the next day or so. I do have a number of questions for you. What do you think reduces the person's pain? Does activity take the person's mind off the pain, or does connection objectively reduce pain in the body?
I might hand this one over to Angela. She's got a lot of experience in this.
I think it's probably a bit of both. Certainly what we know about chronic pain is that if you do have, I guess sometimes life can really shrink in terms of there can be a lot of focusing on the experience of pain as people can tend to withdraw from normal activities that they would usually enjoy, which then can lead to reductions in mood and have other psychological consequences. What we do know is that when you do engage in meaningful activity, it can have that benefit via lifting of mood, improving how you are feeling, to have an impact on turning down your pain, so to speak. Or there is simply the distraction element that when you are focused on something else, that does take your mind off the pain. So pain is very complex, and I think there's a lot of things that can contribute to that. But certainly being engaged and feeling connected goes a long way to providing, I guess, as I say, turning down that experience of pain. Anything to add to that, Shalini?
Thank you, Angela. A comment and then a question. A fantastic outcome given the overall impact of COVID-19 generally on the whole population. Can I ask how you came up with your definition of older adult? I have seen it defined as 55, 60, 65, etc. within other programs.
Yeah, thanks. Great question. That was a question that we grappled with at the start of the project as well, and when we were developing it. And our approach was to take that to our partners at Kota Victoria and take that to our steering committee as well and get their feedback. So Kota Victoria, the peak body for older adults in Victoria. And we got their sort of advice as well on where this intervention fit. And I think the other thing that we're really keen to work on in this project is to draw on the existing literature around social prescribing. And so in our literature review and our scan of what's been done before, particularly in the UK, they were basing those definitions around sort of 65 plus, mainly in older adults with depression or anxiety disorders. And so we wanted to kind of get a similar representative group in our project. So that's how we made our definition.
Thanks, Shalini. Social isolation is a risk factor for elder abuse. Did you observe any concerns?
Yeah, that's a really good question. We didn't in our project, and we didn't have any specific questions, I must say, in our measures to ask specifically about experiences of elder abuse. And so we probably aren't able to kind of necessarily say yeah or nay either way. But also, I think our project was a relatively small pilot, as you see, so probably not hard to be able to answer, that question fully.
Thanks so much. This project is focusing on older adults. Could the social prescribing approach be used for AOD problems?
Yeah, absolutely. I think a lot of other teams in Australia even are starting to do that, as I mentioned. So I would refer people to kind of look at Associate Professor Genevieve Dingle's work in Queensland. And her and her team have been leading a whole range of projects looking at social prescribing, not just for older adults necessarily living with substance use disorders, but people at different stages of the lifespan with substance use disorders, as well as adolescents, actually, where there's another interesting space where social connection is so critical in that developmental life stage, and the lack of social connection can be really detrimental, especially during COVID. So that range of work is again really promising. It really kind of highlights that social connection underpins that process that leads a lot of people to addiction. And it's also so critical in the recovery phase where people are trying to connect with new kind of social networks and connect with new kind of ways to kind of go forward. And so I think it's a really promising space, and probably a space we'll start seeing more and more widely in Victoria as well.
Thank you. This kind of continues on in a way. So this project was delivered completely remotely. Has this been tried before, and could this work elsewhere?
Yeah, so to our knowledge, that approach hasn't been tried before. That was one of the questions we grappled with, I think, when we were deciding whether or not to make that pivot, probably in lockdown number 2, I think, here in Melbourne. And partly, I think the reason it hasn't been tried before is because it is so much about kind of connecting people with their local community. And for us, in a project that was looking at chronic pain, part of getting someone's chronic pain sort of adequately treated is about that functional capacity to be able to leave the house, get out there, and move around as well. And so we had some own reservations about delivering this completely remotely and not completely online. But I think we were probably surprised at our own team ourselves about how successful this approach was, and the fact that it also delivered those same sort of positive outcomes that we would see had the project been delivered in a completely non-online space, in a face-to-face space. That remote delivery and the link worker also being remote sort of opened up that option of potential for this to be delivered elsewhere. We were targeting the Yarra Ranges region, which people might be familiar with, is sort of regional rather than remote. But as a region that has limited sort of internet capacity, limited sort of online reception and connection, had its own challenges about delivering this, but is a fairly large sort of geographical region too. So for many projects like this, social prescribing projects, one of the challenges to delivering it in a region is being able to have that region adequately resourced, so financially and infrastructure-wise, to support that link worker role. So it might mean hiring, for instance, a link worker in each specific community health service. And that's quite a huge kind of cost impost for the service. And so having a remotely delivered link worker function like this kind of raised that possibility that perhaps one person could deliver a link worker function for a number of communities, could actually be potentially a more cost-effective way to deliver that, and a more sustainable way as well to deliver that across a range of communities.
Absolutely. Thank you, Shalini. Did the project interface with the National Be Connected program?
We did. I might throw over to Angela, who had lots of those conversations with Be Connected.
Yes, we did. We actually sought some secondary consultation from the people who run the Be Connected program in terms of getting their specific advice on how best to provide technology to older adults, and then how to, I guess, support them with remote technology support. So we did receive a lot of advice around that area. Part of the interface that we put onto the tablet devices that we provided for loan was a link to the Be Connected, webpage, and we encouraged people to sign up and do if the people who don't know Be Connected provide a lot of online training activities to familiarise yourself with using different devices. So you have different little mini courses you can do to familiarise yourself with a desktop computer or with a laptop or a smartphone. So we certainly encouraged our participants to take part in some of those tutorials and directed them to it. So yeah, we felt that was a very important group to connect with and seek advice from.
Thank you. Are there any Medicare supports for social prescribing agencies or providers?
Yeah, it's a good question. To my knowledge, there aren't currently. That being said, it is very much on that cusp, I think, of being a health intervention that's probably going to take hold in the next 3 or 4 years. So we're probably at a bit of a tipping point of starting to see this being considered. I think in the Medicare support space, I think the lack of a Medicare billing item or support item is one of the main barriers why primary care potentially could not be more engaged in this. There are obviously ways that this could be incorporated into existing Medicare support items, but there's nothing specific to my knowledge, for social prescribing. I'm aware that in other countries, for instance, in the NHS in the UK and in New Zealand, there are also starting to become items that are specifically around supporting social prescribing.
Thank you. I guess I've got some observations from people. Someone wrote, I remember years ago, many years, so someone very experienced, we used a lifestyle prescription, which was an actual script pad to prescribe healthy lifestyle activity, social connections, etc. I can't recall who was behind this, but it was ahead of its time.
Absolutely, Dolly. That was definitely well ahead of its time, and I don't think we have now. We're not allowed to have those prescription pads even in paper, normal prescriptions. So times have changed.
And a couple from another person. This is really interesting, the social prescribing aspect. I'd be surprised if there were appropriate supports or programs at the referral end for this cohort.
Yeah, I think to our knowledge, that they are fairly limited, these sort of programs. And I think it's great to see Bayside Council having a couple of these types of programs in the neighbourhood houses.
Thank you. And from the same person, so many questions. It'd be interesting to source clients via primary health GPs prior to SafeScript and then after the introduction of SafeScript.
Yeah, absolutely. I think, interestingly, I think our project did launch prior to SafeScript, but also just prior to the pandemic. So it's arguable which of those had more impact on this type of project. But I think we did end up delivering a little bit of that right across that rollout.
Thank you. And Sue asked, how did you attract the funding?
Yeah, we were really lucky to have the funding from Gandalf Philanthropy, who are really interested in sort of supporting grassroots community interventions that work across that sort of healthcare space and generate really sort of positive outcomes. And so we worked with Eastern Health and Eastern Health Foundation to work with Gandalf to deliver this.
Thank you. And Sue went on to ask, what would you like to do with this knowledge if you had the funding?
Yeah, so I think some of those key learnings were presented on those last slides led us to think how we could potentially scale something up like this across different communities. And also, I think, as I mentioned, the consideration of how we could bring this across to the addiction treatment space being, a space we're obviously very passionate about. So starting to think about how we could embed that as well with the Royal Commission here in Victoria and that rollout of the local adult mental health wellbeing hubs, how we can support an approach like this across mental health and addiction too.
Thanks so much. I think just one final question. Do we know if community houses are gaining more funding to support increases in social connection in the community?
Thanks, Sally. I think a couple of the councils do have funding for this, but I think where we're at the moment is it looks like many of these programs are pilot programs similar to ours, which is a pilot. And so I think, taking our evidence together with lots of the evidence coming out of these pilots, what would be amazing to see is this kind of investment in a larger program and larger kind of research studies too of social prescribing, because I think we're probably at that point where we've had quite a few pilots. We'd like to see something bigger and scaled in the space.
Thank you so much, Shalini, and thank you, Angela. We'd like to encourage everyone to complete the evaluation, which you can do so via the QR code, which is Shalini's just shared. Alternatively, we will email it to you along with the slides. And Shalini, did you want to show those resources now?
We'll probably email those through as well. Yeah, with the slides.
Thank you. Thank you, everyone, for joining us today.